All right, continuing our discussion of the muscles of the face, going from the elevators of the upper lip to the depressors of the lower lip, starting with the mentalis. The mentalis is known as, you can think of it as the muscle that is the pout muscle. It's responsible for you protruding and pouting out your bottom lip. Looking at this image right here, you can see that it originates on the inferior portion of your chin, and then it reaches up to insert into the lower lip. So when it contracts, the result is the bunching up and the protrusion of the lower lip. Makes me think of Alex Baldwin's Trump impression. The next muscle is the Depressor Labia Inferioris. So we talked about the levator labii superioris. So this is the muscle that opposes it. This is the muscle that depresses the lower lip, Depressor labii inferioris. And you can see it's going to originate down here on the bottom of your mandible, near your chin, and it reaches up to insert into the lower lip. So when this muscle, if it's at this angle, when this muscle contracts, it is going to pull the corners of the lower lip down and out. So this kid is demonstrating the action of the Depressor labii inferioris pretty well. So if you can imagine those muscles right here and right there on his face, pulling that lower lip down. And we had the levator Ankyloglossa, which is the muscle that raises the corner of the mouth. You also have the Depressor Ankyloglossa, and this is the muscle that depresses the corner of the mouth. So looking at this image right here, you can see the Depressor Ankyloglossa, and there's one over here too. And you see how that would directly oppose the levator Ankyloglossa muscles. So the Depressor Ankyloglossa depresses the corners of the mouth, but it's also responsible for pulling down, and it pulls the upper lip down against the bottom lip. So it's responsible also for some compression of the lips together, and that also helps to maintaining appropriate labial seal. The next muscle, the last muscle of the face we're going to cover, is the platysma. We talk about it as in context of a muscle of the face, but it's more of a muscle of the neck. You can see in this image right here that it originates down on your thorax and then courses up to insert into your soft tissues of your mandible, around your mandible, up around into the soft tissues surrounding the corners of the mouth. So it's very much a flat, sheet-like muscle. And when you do this, you can feel it, that wide, flat contraction that's happening all the way across the front of your neck. That is the platysma. And you can see this woman contracting her platysma, and it sort of provides that tensing across the entire front of the neck, and you can feel it all the way up under your chin into the corners of your mouth. The platysma can play a role in lowering the mandible. In other words, it can play a function in opening the mouth. So now let's get into muscles of the tongue. So the main anatomy of the tongue is you have the apex, or the tip of the tongue, and that's exactly what it sounds like, the tip of your tongue. And then this portion back here is also known as the dorsum, or the blade of the tongue. And if you follow the shape of the tongue, so here's the tip, the apex, here's the blade or the dorsum. If you follow it back far enough, it will curl down and forward, and it forms the anterior wall of the pharyngeal cavity. So this part of the tongue is the base of the tongue, although it's also sometimes referred to as the root of the tongue. So ignore this word right there, because I'll use the word root or base of the tongue, and I am talking about this pharyngeal portion of the tongue. And this is also the part of the tongue that has the lingual tonsils on it that we mentioned a couple of lectures ago. And when you're looking at your tongue or the human tongue, you will see that it has this dividing crease that goes down the middle, and that is known as the central sulcus. Your tongue has sensory receptors for taste on it. And it also has this little piece of tissue under it that attaches the tongue to the floor of the oral cavity, and that is known as the lingual frenulum or the lingual frenum. The lingual frenulum is important to know because if it extends too far anteriorly, so too far towards the tip of the tongue, too far towards the apex, and if it's too short, then it's going to be anchoring the tip of the tongue to the floor of the oral cavity. And that is called Ankyloglossa, and it's commonly called tongue tie. And you'll recognize tongue tie or Ankyloglossa when you're evaluating a child and you ask them to protrude their tongue, and it creates a little, when they try to stick their tongue out, you'll see a little heart-shaped. The tip of their tongue is heart-shaped because that apex is being constrained within the oral cavity, and the sides of the tongue are being pushed out around it. And here's another picture. This is my son. So his tongue tie, it's there enough that you can notice it, or you could notice it when he protruded his tongue, but it wasn't tight enough to interfere with his speech or with his ability to manipulate food in his mouth as he's eating. But sometimes that lingual frenulum is so tight that it does negatively affect speech, and it can negatively affect a child's ability to move food around in their mouth. And one of the most famous ways of evaluating for tongue tie is if you ask the child if they like peanut butter, because children that have a really tight tongue tie are famously opposed to eating peanut butter because it gets stuck on the roof of their mouth, and because the tip of their tongue is constrained, they can't rake the tip of their tongue up down their hard palate to get the peanut butter off of the roof of their mouth. So one of the standard questions when you're looking at a child and they have a tongue tie and you want to know, is this negatively affecting the child's life? You ask them if they like peanut butter. Or if you want to further evaluate their tongue tie and you're wondering, is this having a negative effect on his speech? You could go in and you could put peanut butter on the roof of their mouth and then ask them to clear off the peanut butter using their tongue. And then you ask them to open their mouth and you look in there. If that peanut butter is gone, then their tongue is free enough to start at the alveolar ridge and rake all the way back to clear it off. And if the tongue can reach the alveolar ridge to clear the peanut butter, then the tongue can reach the alveolar ridge for articulation. So if they can clear the peanut butter off, it's probably not the tongue tie that is negatively affecting their speech if they are having articulation problems. And you want to be sure of that because when you send them to the doctor to get the tongue tie cut, they will put that child to sleep. So that's general anesthesia. So you want to be sure that you know what you're talking about before you recommend any child be put under general anesthesia. Although when my mom was little, the doc just said, okay, open your mouth, and you stick a scissors in there and clipped it. If you take the tip of your tongue and put it down into your oral cavity, down towards the floor of your oral cavity, you are going to feel those folds of tissue under your tongue. Those are the sublingual folds. And at the sublingual folds, you have salivary glands that are the sublingual salivary glands. Down further in the soft tissue, closely associated with the mandible, you have the submandibulary salivary glands. And saliva is important to keeping your mouth moist, the tissues of your mouth healthy, and it's important for your ability to chew food and make that food into a consistency that is going to allow you to swallow that food. All right, so moving on now into the muscles of the tongue. Like the muscles of the larynx, the muscles of the tongue are also divided into intrinsic and extrinsic muscles. The intrinsic muscles of the tongue are responsible for small movements, fine movements of the tongue. The extrinsic muscles are responsible for gross movements of the tongue, meaning large movements of the tongue. So the four intrinsic muscles of the tongue are the superior longitudinal, inferior longitudinal, transverse, and vertical muscles. And they each work to move the tongue in a different way. And they're intrinsic muscles of the tongue, so they are essentially the tongue. So the superior longitudinal muscles, illustrated here in blue, they're longitudinal, meaning they run along the entire length of the tongue, from the apex back down to the base of the tongue. And so you can see if this blue lines, if I shortened that, it is going to pull the tip of the tongue up and back. So the superior longitudinal muscle of the tongue is responsible for shortening the tongue and elevating the tip of the tongue up and back, as in to the alveolar ridge or to your teeth. So this is the muscle that you're using for the production of your dental phonemes and for production of alveolar phonemes. The inferior longitudinal muscle of the tongue, illustrated here in this drawing with the red, you can see that it courses the length of the tongue, but it does so below, inferior to the superior longitudinal muscle. The inferior longitudinal muscle is responsible for pulling the tip of the tongue down and pushing it into the bottom of the oral cavity. So when I asked you to feel your sublingual folds a second ago, you did that using the inferior longitudinal muscle. That is the muscle pulling that down. And that action is important for production of palatal consonants, such as sh and zh. When you do those phonemes, you're probably going to notice the tip of your tongue gets down in order for the back of the tongue to come up. So here is the action of the superior longitudinal muscle, pulling the tip of the tongue up and back. Here is the action of the inferior longitudinal muscle, pulling the tip of the tongue down and back. The next muscle we're going to talk about is the vertical muscle. Exactly as it sounds, it runs vertically within the tongue, whereas the superior and inferior longitudinal muscles ran front to back. The vertical muscle runs vertically throughout it. So here's anterior, posterior, don't forget that. So if this muscle originates up at the top in the soft tissue of the membranous cover of the top of the tongue, and it runs inferiorly, in a vertical fashion like this, then it makes perfect sense that when these fibers contract, you are going to work to depress the body of the tongue in the oral cavity. So the vertical muscle is important for mastication and swallowing. It's not so much a muscle that you use during speech. It depresses, flattening the tongue in the oral cavity. The fourth and last muscle, intrinsic muscle of the tongue, is the transverse. And so looking at these images here, so now we're looking down on the tongue. This is anterior and this is posterior. So this is the apex of the tongue right here, right? And this is the back of the tongue, back this way. The transverse muscle runs from the lateral edges, the sides of the tongue, and reaches medially to insert into a piece of tendinous tissue at midline called the median fibrous septum. And you can see that if all these green lines shorten, you would see that the transverse muscle works to narrow and bunch up the tongue. It pulls the lateral edges medially, like this, which makes the tongue narrow and all bunched up. And the transverse muscle is also a muscle that we don't use for speech so much as we do for mastication and deglutition.